syndrome, wherein we all need to be very careful what we are dealing with. And when you see a patient of chronic kidney disease, you have to ensure that yes, all those things, all its manifestations or its complications are actually seen, and you have worked the patient up for all those things. So, we will briefly go through the pathophysiology, the risk factors, and clinical consequences. I will just touch about the management part also briefly, because in a session of 1 hour, it is not possible to discuss each and everything. But yes, if there are any queries at the end, please feel free to write in the chat box. We will try to take them up one by one. So, just a second. So I already said, when we talk of chronic kidney disease, the number one thing is that you should understand that it has to be differentiated from acute kidney injury or acute kidney disease or acute renal failure. So the terminology now obviously has shifted from chronic renal failure to chronic kidney disease, so that people understand the importance that there is something wrong with the kidneys. And as we all understand, establishing chronicity in kidney disease, that is the foremost thing. At times we find it difficult also, because patients may not have symptoms or may have symptoms which were not so remarkable, and patients will not come to you. So patients will come to you after a period of time, maybe 3 months, 6 months, or a year. They may be mildly symptomatic or asymptomatic. And when they approach you or you test for them for other diseases, you find that the kidney functions are also deranged. And then you have the problem whether it is an acute kidney injury or it is a chronic kidney injury. So we have to understand that once you label the patient as chronic kidney disease, it invariably indicates that there is a progressive loss of kidney function, and it is more or less an irreversible stage. So you can have some component which is reversible, but by and large it will be an irreversible and a progressive deterioration. So there could be some variations which, if time permits, we will discuss. So the key feature here is, as has been mentioned, is decrease in GFR. Just a second. Yes, sorry. So now this GFR also we understand and we calculate. I will come to that in one of the slides later. So we will discuss that GFR component there. So the decline in glomerular filtration rate. Now, as we all understand, the standard mechanisms to understand the decline in glomerular filtration rate is estimation, which estimation is based upon inulin clearance or urea clearance rate or urea reduction ratio and the creatinine clearance rate. So all those things, but those are not tested usually by us, or at times what best you do is the imaging, the DTPS imaging, that will give you what is the function of the kidney total and the differential kidney function. So that is the way of estimating glomerular filtration rate. But we usually do not do it. So we use surrogates. So whatever chemicals are or molecules are actually excreted through the kidney, so they are used to determine the glomerular filtration rate. So commonly we use cystatin C, although it is costly. So commonly we are not using that here. But what else we use is creatinine and urea. And most of the equations are based upon creatinine. So the reason is also there that urea will vary day to day, but creatinine secretion in the tubules is static. So more or less, so you will not have a very wide variation over a period of time, depending upon your dietary features or other features. So this is also important. So that is why most of the equations are based upon creatinine clearance. But now cystatin C is also available. So that excretion also you can see. So whenever you compute equations, so you will see there will be a mention that this equation is based upon creatinine or this equation is based upon cystatin C. So the other is stages from mild to kidney failure, G1 to G5. This I will elaborate when we talk of how to classify a patient of CKD. So a brief word about the pathophysiology. We understand that there could be two main mechanisms. One is specific initiating mechanism in the kidney disease. So something which actually involves the kidney, harms the kidney. Like we all understand toxins, genetic features would be there. We have a whole lot of monogenetic mutations now which are known. and immune mediated. So these immune mediated could be autoimmunity, it could be immune mediated phenomenon like other immune mediated diseases. So these are specific mechanisms, and then there is a non-specific mechanism wherein we usually do not know the cause. It may be hypertension, it may be a hyperfiltration induced damage. So you have a whole lot of varying diabetes, hyperglycemia. They are not specific related to the kidneys also. They are a systemic mechanisms which actually will also involve the kidneys. So you have glomerular sclerosis, you have RAS activation, and you have podocyte injury also. So there are a whole lot of mechanisms which can be there. But briefly, we should understand. So when you have mechanisms which are chronic, which are accumulating over a period of time, so you need to understand how much reversible or how much of those you can revert. So these are the risk factors. So these will predispose like chronic disease like diabetes, hypertension. These are one of the commonest diseases that you have. So genetic predisposition. So you have a whole lot of genes which are there now. Harrison also gives you a table which are monogenetic diseases which can have chronic kidney disease. Now, in the last 7 to 8 years, previous history of acute kidney injury. So this is also now a risk factor. So when you talk of acute kidney injury, you have that rifle classification, the AKI network classification, AKIN classification. That is for acute kidney injury, mind you. But yes, that RIFLE tells you that risk. Then you have the risk of this thing. mm Risk of having the kidney injury. So RIFLE, the last two are loss of function and end stage renal disease. So risk, injury, failure. So these are things which are partly AKI, acute kidney injury. The L and E, the loss of function and the end stage renal disease. Those two indicate that the patient is of AKI has residual kidney disease. So risk, injury, failure. So those three are AKI, and that AKI can be totally reversible. But loss of function and end stage renal disease. So patient now AKI is considered to be a well-known risk factor for chronic kidney disease. So likewise, it is very important for us to understand that if the patient has acute kidney injury episodes recurrent, so each time there will be some nephrons which will be lost, and so the patient has a greater chance of going into chronic kidney disease later on, much greater than a person who has had only one episode of acute kidney injury. Then again, lifestyle factors like smoking, diet, physical inactivity, so obesity is a risk factor for chronic kidney disease. So remember, you should have a good diet, lifestyle measures, you should have physical activity. Smoking is a risk factor, so quit smoking and tobacco in all forms. Ask your patients. Now, this is a risk factor chart. So, you have a whole lot of diseases we have just discussed. One important thing is nephrotoxic exposure. So, this can be avoided. And in fact, drugs like PPI is also chronic administration can result in kidney injury also. So, this is just to tabulate. I am not going to the details of these. You have viral infections also, you have preeclampsia. So, all kinds of diseases can actually result, but important remains hypertension, diabetes, inflammatory diseases, then you have infective diseases, and you have those lifestyle diseases, lifestyle contributors, which can result in chronic kidney disease. And remember, acute kidney injury, previous acute kidney injury. So this is what I was talking about. How do you stage CKD? So now this classification given by KDIGO, the kidney disease outcome group, a study group with outcomes guidelines. So this is based on GFR and albuminuria, kidney disease quality improvement initiative guidelines. Oh, KDIGO, yes. So based on GFR and albuminuria. So whenever you have a patient of chronic kidney disease, so establish chronicity. Chronicity means that the patient should be having deranged kidney functions for at least 3 months. So that is when you say it is a chronic kidney disease. So patient has to have renal dysfunction and patient should have duration more than 3 months. Then you label as CKD. I will come to a later stage where you will have that summary. So you should have biochemical abnormalities, you can have evidence of kidneys being shrunken, and you can have manifestations of chronic kidney disease. Plus albuminuria. Now, albuminuria is another feature. So, based on GFR, so you should have reduction of GFR and you should have albuminuria and chronicity. These are the things, that means more than 3 months you have to document that yes, decreased in GFR is for more than 3 months. And depending upon presence of albuminuria, you will stage CKD. So the staging could be G1 to G5, which is based upon GFR, and A1 to A3, which is based upon the albuminuria. So it helps predict progression and also guides management. So this is important. And how do we calculate GFR? So what we use is the eGFR. So this is estimated GFR or estimated glomerular filtration rate. At the bedside, we either use equations like these, but which are tedious. So we use apps which are there. Alternatively, you have the Cockcroft-Gault equation. It is not very frequently used now, but yes, it gives you a fair indicator of the estimated GFR because it is simple and you can calculate it at the bedside. But yes, with availability of mobiles, now you can use both these equations, CKD epi also and MDRD also. So CKD epi is chronic kidney disease epidemiology equation, epidemiology network association. So obviously you cannot calculate on the basis of this by your hands. You need a calculator and you need a even a scientific calculator. So now you have apps, you can feed the values in the app and then you will get the estimated GFR. So this is called eGFR. This is an estimated GFR. So you will have equations both for serum creatinine as well as cystatin C. So depending upon what you have used, so if you have serum creatinine level, then you can use the serum creatinine equation. So what I am showing you is the serum creatinine levels equation because this is what we widely use, and cystatin C usually we are not using, but it is more accurate, cystatin C. So serum creatinine values you can put here and you will get the estimated GFR. So greater is the serum creatinine value, the less will be the estimated GFR. So this is important. So we always say eGFR. In fact, at times in your examinations also you will get a question eGFR. Now you should understand that all laboratories ideally they are supposed to write down serum creatinine values and also give an eGFR value. So most of the standard laboratories or those which are accredited laboratories will give you an eGFR value with the serum creatinine value and the method that they have calculated. So they are all mathematically computed. So now once you determine the eGFR and we all understand you determine the albuminuria based upon the urine albumin excretion rate. So then you classify the patient of CKD. So any patient who has deranged kidney functions for more than 3 months, you estimate the GFR, eGFR, and you also estimate the albuminuria, and then you classify. So we all understand that eGFR more than equal to 90 milliliter per minute is normal. So this is important. So you should understand that if it is more than equal to 90 is normal. But if you go through the details of the guidelines and the classification system and the diagnosis of CKD, we still label as G1, which means minimal risk. So this is actually dependent upon the category of albuminuria. So if you have a normal kidney EGFR, but still you have albuminuria, see you come into the yellow category or the orange category. That means you are still at risk of developing CKD, greater risk, and you should be intervened. Similarly, if you have normal this, that is why you will say that we all have more than equal to 90. So we should all get worried if there is any amount of albuminuria. So now this is also dependent upon the structural kidney disease if you have, or if the by the presence of risk factors. So yes, if you have presence of risk factors, if you have structural kidney disease, maybe you have had pyelonephritis and the kidney size is slightly shrunken, then definitely you are at increased risk of going into CKD. So you will have to intervene early in these patients. That is why this yellow, green, red, orange is the prognosis and the intervention. In green, you may not require any intervention. But a patient who is moving from normal urea, that means A1 category green, to maybe earlier the A2 category was called microalbuminuria, but now it is not called microalbuminuria, it is called moderately increased albuminuria. So this is important. So if you have even moderately, what earlier was microalbuminuria, and we considered it was reversible. So now this is considered to be a change in the newer classification, and with moderately increased means that you will be able to reduce or bring it back to maybe normal albuminuria, and there are chances of pre-patient improving also. So that is the importance. The grade of albuminuria will bring to A1 to A2 to A3. So if you have macroalbuminuria, it is more than 300 milligram per gram. So that means it is severely increased, A3. So any amount of macroalbuminuria is basically A3 category. So that is severely increased albuminuria. And you have this G1, G2, G3A, G3B, G4, and G5. So now consider that 30 to 60 ml per minute is actually G3, but we classify into G3A and G3B, and that is why, because G1, G2, G3 are considered more stable, but the G3B stage, that means if you have EGFR between 30 to 44 ml per minute, you are more likely to behave as G4, and you have to be more vigorous. On the contrary, the patients who are in G3A, that means EGFR between 45 to 59 ml per minute, so these patients behave more like G2, and you can still be a little more relaxed, and they may anytime, if you intervene nicely, adopt appropriate strategies for your patients are also cooperative. At times they can move to G2 also. But once you go into G3 stage, it is considered that partly or it is invariably irreversible. But yes, you should have this clarity that G3A will behave more like G2, and you have some windows of opportunity for such patients. So you all understand the degree of albuminuria has a poorer prognosis, and you have to intervene much earlier. And if you have greater reduction of EGFR, again the prognosis is poorer, and you have to intervene much faster. Etiology, we already discussed the risk factors. We all understand that diabetes is the commonest. Hypertension can be the cause as well as the effect in CKD. So CKD patients, once they have chronic kidney disease, they can develop hypertension, and hypertension per se can also result in CKD. Glomerulonephritis is the next common cause, not so common in India, but yes, you have a whole lot of causes. And polycystic kidney disease again may run in families or maybe mutational. But at times, despite the best of efforts or the facilities, you may not be able to diagnose. So those patients are called CKDU. That means CKD undifferentiated or unidentified etiology. So that is what is also a significant group. In fact, that could be more than one third of our patients that we see in India. They do not have an obvious cause. Now, the obvious cause in those scenarios is considered to be maybe environmental, maybe the pollution related contributions, so antioxidant oxidant stress, all those things are considered to be playing a role, at times even heavy metals. So depending upon the environmental factors, they may be playing a factor in that CKDU, although undetermined etiology, because that fraction is not as high as 33 to 50% in other setups. Now, this is what I told you. When we talk of CKD, we talk of the uremic syndrome or the CKD syndrome. So, the constellation of abnormalities may be clinical, symptoms or signs, and the abnormalities that you have on biochemistry or investigational, that together is called as uremia. So, patient manifests in uremia or the uremic syndrome. And this is basically because kidney is the organ for excretion. So, there is accumulation of toxins and hormonal imbalances which results in the uremic syndrome. So the patient may have very non-specific symptoms like anorexia, fatigue, cognitive dysfunction, and this uremic syndrome actually worsens complications because it is a pro-inflammatory state. So the next complication that you can have apart from the manifestation as a uremic syndrome is sodium retention, which results in ECF volume overload as well as hypertension. So you have the abnormalities in RAS, you have sodium retention, and you will have these patients retain water as well as become hypertensive. Now, this is important for all of us to understand that in patients of CKD stage 3B, 4, and 5, this volume increased extracellular, increased extra vascular volume, which is there. The ECF volume overload, which is there, the patient is in volume overload. So this volume overload also contributes to hypertension. So when you give diuretics, when you give these patients dialysis and increase ultrafiltration, and as their fluid overload state reduces, their hypertension also improves. So this is important for all of us to realize that this hypertension can be partly because of the volume overload. So with the when you deal with resistant hypertension in CKD or refractory hypertension in COPD, you have to see in CKD, you have to understand that volume overload could be a important factor. Then talking of potassium retention, so yes, we all understand hyperkalemia is a very big risk in CKD patients, and we need to manage that. So you need to manage dietary modifications not only for hyperkalemia but also for hyperphosphatemia. So both these things, diet has to be a very important factor, and many food items patients will not be able to take because of high potassium, for high phosphate, and sodium also has to be curtailed. On the top of it, if the patient is having diabetes, even sweets have to be curtailed. So there is a problem. CKD patient is otherwise also anorectic as part of the uremic syndrome. There is accumulation of toxins and patients lose appetite. On the top of it, patients also have uremic gastritis. So all these factors together, there is a big problem. That is why we talk of it as a uremic syndrome or a CKD syndrome. Similarly, acidosis. These patients develop metabolic acidosis and there is loss of ammonia excretion. That is the reason. Now, the next set of abnormalities are bone and mineral disorders. Now, this is actually called as CKD MBD. Earlier, it was called as renal osteodystrophy, but now it is known as chronic kidney disease, mineral bone disease. So, CKD MBD, which is the term, and this also comes as a short note. And if there is some person who has interest in kidney, this can come as a long question also in your papers. So, CKD MBD is a very frequent question, and you should understand the integrities of the CKD MBD syndrome. Uh, I would not be able to discuss it in detail, but yes, when you talk of the mineral bone disease, you should understand that there is are two basic classifications which are poles apart. One is high PTH state, where you have this characteristic is osteitis fibrosa cystica, the hyperparathyroidism state. The other is a low turnover bone disease where the PTH levels come down and are near normal. So this is the stage of adynamic bone disease, which is not good for the patients. So this is important that you have to understand the adynamic bone disease means that the patient will be having a problem and the bone turnover is low. So you are not able to replace the bone, and this is a very difficult state because you want that the bone should, because usually in CKD patients the bone turnover is very high. They develop osteoporosis, they develop fractures. So that is what is important. You should understand high PTH is the normal state where the patient has hypocalcemia, patient has low calcitriol levels because the kidneys are glomerulose. So you have normally high PTH. At times with therapy, when you try to bring down the high PTH or you give calcium supplements, the patient may have slightly lower PTH levels, but don't get the PTH back to near normal. It should not be normal. Once the patient gets into the normal PTH level, you have supplemented enough, the patient can have a low bone turnover disease or adynamic bone disease, from which at times it becomes very difficult for us to revive the patient and bring the bone back to its remodeling state. And yes, obviously, there was an earlier concept that yes, hypercalcemia or high calcium phosphate product can result in vascular calcification. Although that is no longer there, but yes, hyperphosphatemia can result in vascular calcification and also the risk of fractures. So talking of cardiovascular complications, now this is very, very important. I already talked to you about fluid overload. Fluid overload results in a also hypertension, and hypertension in CKD is virtually sine qua non. If you have glomerular disorders or chronic glomerulosclerosis as a cause of CKD, you will invariably have hypertension. So 90-95%, maybe 100% patients of glomerular sclerosis will have hypertension. But if you have, on the contrary, chronic interstitial nephritis as the cause of chronic kidney disease, the prognosis is far better. Only 10 to 30% patients of interstitial nephritis or CKD having CIN as etiology will have hypertension. But yes, remember, hypertension is virtually, most of these diseases are chronic glomerulonephritis diseases, and glomerular involvement is invariably there. So CKD usually has hypertension with it, and fluid overload contributes to hypertension. Remember that cardiovascular complications are the leading cause of death in chronic kidney disease. Chronic kidney disease patients don't die easily of metabolic acidosis. They will die of cardiovascular complications. Even metabolic acidosis, when it causes death, it is through cardiovascular causes. It is called because of arrhythmias, hypotension, that metabolic acidosis causes, that the patient dies. So you should understand that CKD, cardiovascular complications, need to be prevented and treated. So you can have left ventricular hypertrophy because of hypertension. You can have an enlarged heart because of heart failure, chronic fluid overload can result, and you can have arrhythmias, which can be because of the disease entity or it could be because of metabolic acidosis. So risk factors, obviously all traditional risk factors plus CKD specific. So when we are talking of pathophysiology, FGF23 is also there, which is now considered to be a very important factor resulting in more of fibrosis and systemic complications also. Similarly, anemia. Remember, if you correct anemia, you will reduce fluid overload, you will reduce hypertension also, and you will improve quality of life. So very important. Long-standing anemia will also contribute to LV hypertrophy in addition to hypertension and in addition to fluid overload, which will also be contributing to LVH. And obviously, then it can be resulting in CAD or chronic coronary artery disease, resulting in ischemia. So this, I think, we have discussed. Hypertension in CKD could be a cause as well as a consequence. Raw salt restriction is important for hypertension, for CKD, for fluid overload. Ideally, hypertension in CKD should be managed with ACE inhibitors and ARBs, and I told you diuretics to for fluid overload. But importantly, if the patient has gone past CKD stage 3, you have to be very careful using ACE inhibitors and ARBs because they also have the propensity to cause hyperkalemia. We discussed that in CKD, patients may have electrolyte abnormalities like sodium retention. You can have hyperkalemia and hyperphosphatemia apart from metabolic acidosis. So can have hyperkalemia if you are using ACE inhibitors or ARBs, which also can cause hyperkalemia. You have to be very careful. You should monitor potassium frequently. Patient should be compliant with a low potassium diet. Otherwise, the patient can go or the patient can develop hyperkalemia and go on to develop severe life-threatening arrhythmias, including cardiac arrest. Now, anemia in CKD is very, very important for all of us to understand. We all understand it could be because of number of factors. Number one reason is obviously the erythropoietin, which is formed by the kidneys. Since the kidneys are diseased, so erythropoietin is not being formed. Number two, we already discussed anorexia. So these patients are anorectic, they have toxemia already, and they are not able to have a good diet. So they are not able to consume. So poor nutrition can also contribute. The other thing is you also have uremic gastritis. We discussed about it. So tolerability to oral food as well as iron or iron containing foods may be difficult. At times you can have very severe uremic gastritis leading to bleeding also. So CKD is also associated with altered bleeding diathesis also. So you can have bleeding from various sites. That can also be an ongoing blood loss. Plus, because of the uremic syndrome, the RBC survival time is also reduced. So you have poor RBC survival because of the toxins which are already there in the body. So the RBCs, they go apart or fall very fast, or they don't survive as long as they should. So there are several causes of anemia in CKD, and you will need to take care of a very proper history. So luckily now for the last quarter of a century, we have ESAs or erythropoietin stimulating agents which can be used, and we have iron supplementation also, and the fear that we had with anaphylaxis with iron injections is also much less now. And iron supplementation is very frequently used for CKD stage 3 and above, stage 3, 4, and 5 patients. So it is important. And many times you will see iron being given during dialysis, which is important also. So now, when you are when you are about to start these patients on ESAs or erythropoietin stimulating agents, you should understand that there is an entity called functional iron deficiency. So, if the patient is not already iron replete, then you should understand that these patients, if they are not already iron replete, will develop iron deficiency, because if you give erythropoietin, what erythropoietin will do is it will start erythropoiesis or stimulate erythropoiesis. And if you do not have iron, adequate stores of iron in your body, it will consume all the iron and it will result in a iron deficiency state, what is called as a functional iron deficiency, because this iron deficiency has been produced by your giving erythropoietin. So what will happen? The patient will become iron deficient. So you will have iron deficiency symptoms. More importantly, that the erythropoietin that you are giving is useless. So it is not going to benefit your patients, and the money and the resources are going to be useless. So you have to understand that erythropoietin has to be used. Erythropoietin or erythropoiesis stimulating agents like erythropoietin, darbepoetin, you can use. Even roxadustat is there, which is an HIF PLI, the hypoxia inhibitor factor inhibitor agent. So these all can be used and are used in several patients, and you can use these patients, but ensure that the patient is always iron deplete. So for that, you get serum ferritin agents at times periodically, so that you understand that your patient is having iron stores adequate. So ensure that the patient's ferritin level is more than 100. Then only you should, nanogram per ml, you should then only start the patient on ESS. This is very, very, very important. This I already said, hemostatic abnormalities. So because of the presence of the uremic state or because of the toxins, you have prolonged bleeding time, which also can contribute to iron deficiency and anemias. So you have both risk of bleeding as well as thrombosis. So you have to be very careful. And dialysis obviously does revert some amount of hemostatic abnormalities, but you may have to resort to other agents also. But yes, once you bring down the uremia down, you have a fair control of hemostatic abnormalities. Now, I would like to mention here, if your hemostasis is not controlled, remember whatever fluid spaces are already occupied. You have a fluid overload state in CKD, you have pleural effusion, you have ascites, you have pericardial effusion, and because of bleeding, any of these cavities, fluid which is there could be blood. So you have hemorrhagic pleural effusion, you have hemorrhagic pericardial effusion, you have hemorrhagic ascites, all could be there as part of, because of hemostatic abnormalities and fluid overload. Now, neurological complications are very important. In fact, this is one indication for dialyzing your patients if your patients are not improving. So, if you have uremic encephalopathy or the patient has confusion, seizures, cognitive dysfunction, they could be because of again accumulation of toxins. So, these are patients usually you see in 3B, 4, and 5 states. Peripheral neuropathy may be there. This is again CKD associated, chronic kidney disease associated peripheral neuropathy, and restless legs. Yes, but remember, all restless legs are not CKD. But yes, there is a greater propensity for CKD patients to develop this restless leg syndrome. And at times they will be refractory. Maybe dialysis can improve them, but more or less they are very troublesome for the patients. Yes, dialysis can reverse many effects. So uremic encephalopathy is a indication for dialyzing these patients. But remember, if you dialyze the patient of a uremic encephalopathy or even a conscious patient and the urea creatinine is very high, the first dialysis or after a long session, the patient may again go into dialysis disequilibrium or may become disoriented. So this entity also you should know, this is a dialysis related complication. So whenever you dialyze a patient who has a very high urea creatinine level, and the patient goes first. You put the patient on dialysis the first session. So even after that is why we keep the session short and we don't prolong the first dialysis of the patient. So we dialyze for 1 hour, 1.5 hour, or 2 hours. We don't dialyze 3 to 4 hours the first dialysis if the blood urea serum creatinine is very high, because otherwise these patients go or become obtended or become unconscious, and this is known as dialysis disequilibrium syndrome. The gut and the nutrition, yes, very, very important. We all understand uremic patients at times in CKD stage 3, 4, you can have acidotic breathing, you can have fetor, you can have this uremic fetor, and the patient anyways can have nausea, vomitings, uremic gastritis, so, and he or she is anorexic. Remember, again, malnutrition is very important in these patients, and it will be very, very difficult for you to give them proper nutrition. But that is a very important part, especially if you are putting the patient on dialysis or peritoneal dialysis or hemodialysis. You will need to take care of the nutrition. And if the patient is able to have good nutrition, his prognosis and deterioration. So prognosis improves and deterioration reduces. Taste disturbances are there, and as I said, yes, dietary intervention monitoring very important. Hyperkalemia, hyperphosphatemia, hypocalcemia, anemia, all these things you will need to manage with diet. Very important. Endocrine disorders, yes, CKD is a pro-inflammatory state and insulin resistant state also, and you can have glucose intolerance. But importantly, as I already said, most of these patients already have diabetes as a cause. It is one of the commonest causes. If you leave the undetermined etiology CKD alone, then diabetes is the foremost cause. Yes, CKD patients develop infertility, they develop amenorrhea, so they can develop impotence. So the sex hormone balance is also gone. And in pregnancy, although these patients, because CKD stage 3 to 5, they have greater chances of being infertile or impotent. The risk of pregnancy is very less. But yes, if there is a pregnancy and the patient you diagnose the patient to be having CKD, so the chances of the patient going into preterm labor are more, and obviously pregnancy is a stress state, so progression to CKD is more likely also. Dermatology manifestations, yes. Uremic pruritus, we all understand. You can also at times those who are very severely or EGFR is very low, at times if you just touch their skin, you can see white sediments also, which is actually urea. And these patients develop hyperpigmentation. Calciphylaxis, yes, very troublesome symptom. You can have calcium deposits under the skin, which then just ulcerate, and you can have ulcers which are non-healing or big ulcers and very painful. So these occur in advanced stages, and dermatological manifestation could be really very problematic. You don't want to give antihistaminics to these patients. Pruritus may not be treatable unless until you dialyze the patient, and even after dialyze also. Now, this is important. Now, although most of the newer agents are also quite safe, but initially there was a systemic fibrosis that was seen when gadolinium was given in patients of CKD. That is why you will see that yes, they still get a blood urea serum creatinine, and if they are normal, then only they continue with giving administration of contrast, not only to prevent contrast associated nephropathy, AKI, CAAKI, contrast associated acute kidney injury, but yes, even allergic reactions or systemic manifestations with gadolinium also. So you want a good kidney function before these imaging studies. Now, this I have already touched around, but I will just say it. For diagnosis, you should have a 3 month history or evidence that this is a chronic irreversible state, plus an EGFR estimation. So you have already seen how to classify, and ultrasound of the kidneys can be helpful when you see that the kidney size is shrunken, there is loss of corticobundary differentiation. So these are important things which you want to see on ultrasound. At times in states like diabetes, amyloidosis, the kidney size may be normal, but loss of corticobundary differentiation is an important feature in such patients. Management principles would be depending upon the etiology. So you have Risk factors you need to control. So the etiology, so that there is no further worsening. So blood pressure, glucose, as well as lipids. Avoid nephrotoxic agents, very, very important. They contribute to development of CKD. Once you have CKD, they further deteriorate the progression. So you will have further or rapid reduction in CKD if you continue taking nephrotoxic agents. Importantly, NSAIDs and to an extent PPIs also. So monitor and treat for complications. We have tried to address most of the complications, but you will need to treat them appropriately, which is very, very important. And prepare for renal replacement therapy in advanced stages. So the right time is when your patient moves to stage 3B. You should prepare the patient very from 3A to 3B. You should get the patient prepared. At 3A, start priming the patient that yes, your control has to be very good because otherwise we will have to move ahead. You will have to prime the patient in 3A. But as the patient moves from 3A to 3B, you will need to prepare the patient for renal replacement, either renal transplantation or alternatively you can have other hemodialysis or peritoneal dialysis measures. So you will need to prepare the patient for such modalities. So you need to get a fistula made if the patient is going for hemodialysis, and you have to guide the patient how to go about it. So just to conclude, CKD is progressive and systemic. This is very important for all of us to understand. A mere urea creatinine abnormal, ensure it is a chronic disease. It is because it is irreversible. It will progress over time. Even if it is chronic interstitial nephritis, then also it may progress over time, although it may progress very slowly, unlike CG and chronic glomerulonephritis. Early identification and intervention are very, very important if you want to retard the progression. And multi-system complications will require comprehensive management, and you will have to be very, very adept because there will be too many complications and too many intricacies in managing these patients. It is not easy for me to cover in such a short time, but still I have tried my best, and the management would still leave a lot many things still I have not touched. But you will need to go through, and as you see the patient, please go through the complications and screen the patients. I told you, diagnosis of CKD, one is paramount because you need to intervene and prevent further deterioration. Search for etiologies, treat the etiologies, and also screen for complications, the next stage, so that you prevent complications, and if any complications are present, treat them also. Well, thank you. I think there are a couple of questions in the chat box. I will just take them. So gut kidney axis I have covered. Renal failure can cause hepatic complications. Yes, renal failure can cause hepatic complications. It is not part. It is basically a pro-inflammatory state, and you Renohepatic syndrome. I am not aware of if that classification has come, but because of the pro-inflammatory state and because of the fluid overload and the insulin resistance which occurs because of the pro-inflammatory state and because of a number of other factors, the liver will be involved. And yes, chronic kidney disease patients or uremic patients can develop hypoglycemia, even if they are not diabetics. And if your kidney liver is also diseased, then definitely it will contribute. So there are a number of factors. As I said, it is a syndromic diagnosis. There are so many toxins which will affect the liver also. But liver is actually not, it is a very important metabolic organ, but it is not considered an essential organ. So you have the kidneys, you have the heart, you have the lungs, and you have the brains. So they are all important. Liver is a sub-vital organ, but yes, it is important for you to take care of it if you have the amenities to take care. So CKD patients, yes, as I said, obesity is a risk factor. So if you're taking care of obesity, you have to take care of these patients also. This is important that these obesity patients who have a risk factor for kidney disease will also have a risk factor for liver disease. So you need to take care. So if you revert obesity, your liver as well as kidneys will be better. But yes, I have not gone through this the term that you have used, renohepatic syndrome. So hepatorenal syndrome to we all have studied, but renohepatic I have not read right now. So anyhow, role of iron therapy, I think we have discussed. Oral iron, yes, you will need to supplement. See, what probably this question indicates is you see these CKD patients, they are being given IV iron therapy every fortnightly when they are coming for dialysis. So, iron oral is a good therapy. But the thing is that patient will have to take twice a day or thrice a day. And because the patient is already anorectic, and CKD patients at times have diarrhea, loose motions also. At times they have severe constipation. And iron also behaves abnormally in these patients. So it is very important for you to understand that these patients may have intolerance to iron. They are already anorectic, they are having uremic gastritis, they may not like to take iron. So if they are on dialysis, anyways, you have an IV access there and you are taking out blood and returning blood. So when you are returning blood with that, you can actually give a whole lot of medications. In fact, if at all we need to give blood transfusions also, we plan them during dialysis. So we give these iron therapies, IV iron therapies also during dialysis sessions. So don't take it that oral iron therapy is not important in patients who are not on hemodialysis. You will need to ensure oral iron. Otherwise, alternatively, what you can do is before starting ESAs, erythropoietin stimulating agents, erythropoiesis stimulating agents, you can give IV iron to patients if their serum ferritin is less than 100. This is the normal practice that we all follow. Then there is, if PTH is very much elevated, when to start vitamin D or calcium plus vitamin D3? This I have already dealt. So you will have to be very careful because you want the PTH to come down. So start calcium, there is no harm in that. And the concept of starting calcium first and then vitamin D later, that still holds, but with a number of other agents now, and that calcium phosphate product going out, it is not essential that you will need to go sequentially. But what we do in practice is we start calcium and later on start vitamin D. But you can start at what phosphate level will we give sevelamer? So if any patient has hyperphosphatemia, so sevelamer is effective. So in bringing down phosphate levels, so if your diet, if the patient is not controlled on diet, Sevelamer is a little costlier agent, so you can start these patients on Sevelamer and advise the patient to take Sevelamer with meals because the main source of phosphate is diet. So you have to be very careful. Will we give tab nodosis to all patients with CKD daily? So yes, that will depend upon the biochemical abnormalities that you have. If you have, you will need to give the CKD patients. All these you will need to correct all these medications. Now, can medicine practice dialysis? Most of our medical practitioners are doing dialysis in hospitals. The legal provision outside you will have to see. You should have some experience and good experience of working in a dialysis unit. Then I don't think there should be any problem in doing a dialysis. It is we have been doing dialysis for a long time, pretty otherwise also. Sequence of adding an antihypertensive drugs in CKD patients and target BP. So these are very difficult things that when you have. So what do you want to add? When do you want to add? Will depend upon the patient and the development of side effects. So in CKD patients, obviously, if in till CKD 3A, you can safely add ACE inhibitors, ARBs, because they will take care of the RAS system also. The patient is not in very great fluid overload also. But as you go down, so calcium channel blockers, alpha blockers are very effective agents. So these patients, you will like to remove ACE inhibitors, put them on calcium channel blockers if they are not already on calcium blockers. And these are the patients who have fluid and you are yet not on dialysis. So fluid overloaded and yet not on dialysis. So you need to give diuretics, loop diuretics. And then you will need to add these patients on maybe centrally acting agents like clonidine. So many of these patients, because by the time they reach stage 3A or 3B, they are already on 3 or 4 antihypertensives. So you actually need to give prazosin or alpha blockers, and you will need to give centrally acting agents like clonidine or the newer congener that we have. So these are the drugs which will be very effective because centrally acting agents bring down blood pressures much better way as compared to ACE inhibitors or ARBs and even calcium blockers. How to differentiate AKI and acute or chronic kidney disease in old age patients with grade 1 RPC changes. So, see, acute and chronic kidney disease, most of these CKD patients that come to you will have some component of acute kidney injury. That is why they come to you. So, this is important that you have to understand that any patient who is otherwise coming to you as CKD for regular follow up also, search for reversible factors, search for an acute worsening, because if you have a component of AKI and you neglect it, it may get treated spontaneously or it may continue. Maybe fluid, the patient is fluid deficient. So he will have a worsening of kidney injury if you do not take timely management. If the patient is having UTI, you don't specifically ask for symptoms and patient does not tell, then the UTI will progress or the UTI will be treated at a later stage. You search for the reversible factors. Then you will be able to better manage and detect these acute conditions or acute worsenings. And the patient will be better off also. Vitamin D we have discussed. Selenium best CCB in CKD is not there. You can use any CCB. Their CCBs have their advantages or disadvantages. So it is not always necessary that you have to give cilnidipine only as the best agent in CKD. So you have a whole lot of studies which are there, and people use all types of calcium blockers. Importantly, you should understand that yes, use drugs which are renoprotective, use drugs which will bring BP control. And if you are able to reduce the volume, this is very, very important. So I think we have taken care of most of the questions. Any other questions? Anything? I understand there will be 10, say, more, 10, many more questions, because when you deal with these patients are really very difficult to control blood pressure, to control anemia, and there's a lot of it. If you should go and study also, there are reasons for erythropoietin resistance, anemia, which anemia again comes as a long question. Or in our times it used to come. Today it will come as a short note or a semi-long question. But CKD syndrome is important for you to understand. And hyperkalemia management, hyperphosphatemia management, these things are very, very important. Remember calcium also, when you give calcium for calcium carbonate, you avoid when the patient has hyperphosphatemia, and you try to shift the patient to calcium acetate. So that is one thing again, because you don't want that there should be dystrophic calcification. But there are a number of concepts which are there, and you will need to actually go study and then again see your patients. In an hour's time, it is very difficult to tell you. Soda bicarbonate, you don't actually need to give unless until your patient is acidotic. So it is not pH level. You need a patient of CKD to be stable. If the patient is not stable, you will need to admit the patient. Don't treat on OPDs. Yes, some patients will have a chronic acidotic state where you will prescribe oral calcium carbonate, which gives you carbonate also, or you will write down bicarbonate. You have powder bicarbonate also, pulverized soda bicarb, which you give these patients. But you will have to be very careful, because these are chronic states, and it may not be always possible to rectify all the abnormalities on OPD basis at times. I think that is it. We will call it a day then. Thank you. And look forward. You all have to give the examination also. The question paper will be set shortly, and I think we are having the examination in September probably. I will get the dates mentioned on the group. Well, thank you. Thank you so much.